Well, I've been at this for a long time, and I've worked intensively with researchers all over the United States and in Europe. And I'm going to try to summarize 50 years of research by several hundred researchers in one 45-minute talk. And we'll see how well we do. Let me see if, yeah, here we go. So first, before we get into how to treat it, let's consider the history, the nature of obesity in humans. This is a condition that typically develops over the lifespan. There's increasing evidence that experience, even in the first trimester of pregnancy, may have a lifelong effect on chance of becoming obese. Patients have a high motivation to manage their weight for a healthy weight, and yet this condition is very resistant to treatment. What's happened in the last 50 years is the prevalence of obesity has gone through the roof, as we all know. If you look at films taken in public places from 50 years ago, it's amazing how thin everybody looks. And now a third of the population is obese, another third's overweight. And if you get into older groups, the prevalence is higher than that. Now, everybody has their theory or their personal hypothesis about why we have this obesity problem. But let me just point out that the genetics have not changed in the last 50 years, but the prevalence of obesity has. And that's happened in every ethnic group in the United States, every age group, every region of the country. The same thing's happening now in Europe and in Japan and other countries. So it's not a local problem, it's a national and international problem, it's not a genetics problem. Well, let's see if we can learn something about this. So here's what I'm going to try to do today. I'm going to start by talking about how we measure success, which is an extremely important issue if you're choosing which program to implement. I'm going to talk about which treatments don't work, which treatments do work, and how to integrate effective treatments into medical care. All of my weight loss research has been done at the Kaiser Permanente Center for Health Research in Portland, but much of that research has been national work. I've been a part of large-scale, multi-site national clinical trials as well as lots of local trials. But I've always been working from the point of view is how can we get this into routine medical care? If I don't get into that enough, ask me some questions about it later. Now, large numbers of creative scientists from every discipline have worked on this problem for decades. Lots of very creative, bright, hardworking people from every discipline you can imagine. Everything you can think of has been tried, plus a lot of things you probably never thought of. Even the miracle grapefruit diet has been systematically tested in clinical trials. Only a few treatment strategies work for more than a few months. Almost anything works in the short term, but the standard in the field is what's happening at 1 year, and better yet, 3 or 4 or 7 years in the future. And so very little works. How do you know whether it works or not? Well, you need to use measured weights, not self-reported weights. It's not that people lie, it's just that they say what they're going to weigh. Probably no one here has ever done that, but we say, what do you weigh? Well, by Sunday, I'm going to weigh 5 pounds less. When you look at treatment programs, one of the standard things in medical research is to assume that people are missing follow-up data at random, but that's not the case with weight studies. If you're doing weight loss intervention studies, people drop out when they start to gain weight. And so whether they come back or not for follow-up assessment is often related to how much weight they have gained. Here's a question I often get. I call up people that haven't come in, and I say, you got to come in and weigh, we're trying to finish the study, and they say, you don't want my weight, doc, I've gained weight. Yeah, we do. If we really want to know what's happening, we want to know what happens to every single person. So I'm only going to show you data from studies that have had high follow-up rates, 80, 90% follow-up rates. We're getting 90, in the really high quality trials, 90% follow-up at 3 to 4 years, measured weights. There's a lot of crap in the literature where people are getting 30 or 40% follow-up rates and publishing that and trying to compare it to studies that have 90% follow-up rates. So that's something you really want to consider. So here's some of the studies we've done at the Center for Health Research. I don't have time to go through all of them. The first one, Freedom from Fat, was a straight-ahead patient treatment program. It was a pilot study, over 3,000 patients. I worked full-time as a health counselor in that study for 5 years. We published the results from that. Fight Against Fat was a weight loss program we did on television and had participants actually weigh in on broadcast television. Worked great. TOHP 1 and 2 were big national clinical trials. I was the chair of the weight loss committee for those trials. Premier was a study on weight loss and blood pressure. I don't have time to go through the rest. Let's see. Obesity prevention at the work site was a study that we did in multi-ethnic populations in Hawaii, hotel employees in Honolulu, which was many different ethnic groups. Steps for Soulful Living was with African American women. We've done a series of follow-up studies on that. De Por Vida is a study we've done with Spanish-speaking immigrants, mostly from Mexico. That research continues, and I understand some people here have a strong interest in that. If I don't get to it, please ask me later. Healthy Moms was a study we did with women in pregnancy, did a weight management study. Obese women, counseled them not to gain weight during their pregnancy. Fascinating research. Prepare is a current study that we're doing with women that are in preparation for pregnancy and then following them through their pregnancies. Okay. Here's what doesn't work. None of these things work. I wish they did, if only. Right? Advice to lose weight, total zero. In fact, if anything, it makes people nervous and they want to eat more. Education about the health risks of obesity has no effect. Psychotherapy, which a lot of people think would work, has been tested in many randomized trials, never has been shown to be effective. Hypnosis, again, if only. You know, we want a simple, easy solution. Hypnosis sounds like it. Doesn't work. Might work for a few days, but it doesn't work over the long haul. Stress management training doesn't work. The patients like it. It yields good, mental health benefits, but doesn't help with weight loss. Special food combinations have been tested. If you just eat this combination of food, you'll be fine. Doesn't work. Nutrition education doesn't work. Otherwise, there'd be no overweight dietitians. Exercise education, so on and so on and so on. None of these things work. Here's what does work. Residential treatment programs. If you put people in a residential program where you have total control over what they eat, boy, do they lose weight. And there have been a couple of really interesting studies with this. One in the VA where they had participants for a full year. These were super big guys, and they brought their weight down beautifully, but as soon as they leave the program, they start to gain weight again. There have been other residential programs. They work great. Multi-session outpatient behavior change counseling, which is my specialty, works really well, and I'll show you some data for that. Longer intervention programs work better than shorter programs. Short programs are really not much value. You know, you see weight loss programs 4 weeks, 6 weeks, 8 weeks. No one in the field thinks those are worth a damn, because as soon as you end the program, then you go right back. They're too short. Okay, so this is effective treatments, and this is across the board. The primary emphasis in effective treatment programs is changing participant behavior, not providing information, not trying to help them get insights, not dealing with their internal conflicts, simply trying to get them to change what they eat. Focus on nutrition and activity habits is what's effective, and helping participants learn how to modify their personal environment to support sustained behavior change. What do I mean by that? I mean not having the foods you have trouble with at home. That's modifying your personal environment. Making arrangements with friends to be part of an exercise program. That's modifying your personal environment. So the more you can change the world you live in, the greater effect that's going to have on your behavior. We can teach people how to do that. with weight change as the primary goal, not insight, not diet change, but weight change. We measure weight frequently. Those programs do much better. And sustained contact. Look, the world we live in is an obesogenic environment. You can't walk down the street and not see fast food places. Everywhere you go, there are highly attractive, calorie-dense, cheap foods available. I mean, you go to an electronics store, they've got chocolate and chips. The world we live in now is just jam-packed with this stuff. There are thousands of food experts in the food industry figuring out how to develop new foods that are highly attractive, package them in clever ways, advertise them. There's huge pressure to gain weight. Are you with me on this? And we're pushing back. So imagine if all of you were pushing one way and I'm pushing the other. It's about what it's like. And so what would make us think that talking to a patient for a half an hour every couple of months could possibly counteract that ongoing pressure? Whew. All right. Okay, high-quality behavioral treatment programs are quite effective. A majority of the participants will achieve clinically significant benefits in weight. That's usually defined as at least 5% drop in weight, but 5% or more. Most participants who achieve clinically significant weight loss will maintain a significant weight loss for at least several years. That's in direct opposition to the myth that most people gain it all back. That's not what happens, and I'll show you some examples. And behavioral treatments are cost effective. Now, when I was on the National Guidelines Board, the surgery people were saying they thought that stomach stapling or other surgical methods should probably be applied to 10 to 20% of the population. Can you imagine what that would cost? Behavioral treatment programs are much cheaper. The drug companies are trying to come up with stuff that would be a pill that would take care of everything at $5 a day. Well, no matter whatever they cost to manufacture it, that's what they'd sell it for. Behavioral treatment programs are cost effective. So there are side benefits to behavioral treatment programs. These are just a few. Brings your blood pressure down. We've done a number of studies on this. It shows that you can delay the onset of hypertension in people that are likely to develop hypertension. It brings down blood pressure in people that are hypertensive. They reduce the amount of medication they take. Improve glycemic control. Weight loss has been shown to at least postpone the onset of diabetes and in some cases reverse diabetes. There have been several large national clinical trials testing that. Joint pain, reduced apnea, cheers you up. This is what works best for the first 6 months. Weekly group meetings is absolutely the best. That's the gold standard. And the longer the series of weekly group meetings, the more effective the intervention becomes. And what do you do in those meetings? You make and disclose short-term goals and action plans at each meeting, achievable things. What can you do in the next week? Short-term, not long-term, short-term. What changes can you make? The focus is on energy, reduction of energy intake. That's really the key thing. The best way to do that is to keep some kind of food diaries. Now, I'll talk more about that in a little bit, but what's in that food diary can be different. There's different approaches. It can be calorie counting. It can be portion counting. There are other approaches, but keeping records of what you're eating is key. Modify the personal environment to support new behaviors. And then accountability. Weigh them at every meeting. Have people talk about it. How'd your plan go? What did you do? Did it work? Didn't it work? If it didn't work, what can you do differently next time? Problem solving. The weight loss is about reduction of energy intake. When you compare exercise and diet change is 90% of the battle. And physical activity really plays a minor role. I'm not putting down physical activity. It's very important. It has benefits completely independent of weight loss, but it's not a good strategy for weight loss. It's got to be diet change. Predictors of initial weight loss in the big programs. The more group meetings people attend, the better they do. When people are randomly assigned to more or less meetings, the more meetings they go to, the better they do. Number of food diaries kept per week is always the highest predictor. We've published this many times. This came out in a big weight loss maintenance trial we did. We showed this about, got a whole lot of press about 10 years ago. Food diaries are the greatest thing. We'd published on it 25 years before, and nobody was paying attention. But in all the big studies have shown that that's a high predictor. Early weight loss, if people don't respond within the first month, they're not going to respond, and it's time to move to something else. The more they weigh when they start, the better they do. And the most important result, the older participants tend to lose more weight and are more successful at keeping it off. Now, that's one good thing about aging. Yeah. Okay, both group and individual programs work. Group programs appear to be more effective on the average, the nearest we can tell, but individual-based programs also work. Group programs have the benefit of they're less expensive. Large groups work well. A good, very experienced counselor can work with groups of 20, 25 and get good results. Now, group versus individual counseling. This is an interesting study done by Resilian. They rounded up a bunch of people for a weight loss program, asked them whether they preferred group sessions or individual sessions. Then, regardless of what they said, they randomized them to either group or individual. So the ones that were assigned to group are in the red bars there. And PG is preferred group and NG is preferred individual. And there's no difference. It didn't make any difference. Whether they preferred group or individual, they did equally well, and the groups did slightly better. Longer treatment produces greater weight loss. This is a really important point. Keep in mind, we're pushing back against the environment, and that doesn't go away. So if you're taking away the counter pressure, you're leaving people with, it's not surprising they have trouble. The length of intensive treatment and the average weight loss are directly related up to about 6 or 8 months. And in spite of what people say, if you're good at it, a large proportion of the participants will keep attending group meetings for at least 6 months. They don't necessarily love it, but it works. Here's one where participants were randomly assigned to 20 or 40 group sessions. So 20 weekly sessions versus 40 weekly sessions. And let's see, I think this is 20 weeks and this is 40 weeks. You can see they keep losing weight. They start gaining weight a little bit after the end of treatment, but look at the difference out at well past a year. So the longer you treat, the better it works. Now, I talked about short-term, now long-term strategies. What works in the long term? We found that ongoing group or individual counseling sessions continue to have a measurable effect at least 3 years. And we've done that in several large studies. Here are the strategies that seem to work. The people that weigh frequently tend to do better than the people that don't. The people that keep off weight over the long term tend to exercise quite a bit. I don't know if that's because they burn more calories or just because it's hard to eat while you're exercising, but in any case they do better, and we would recommend the exercise for everyone anyway. The people that do better are the ones that never make an exception for their dietary plan. They're going to stick to what they're going to eat, no matter if it's their birthday, Christmas, Arbor Day, whatever. They stick to it. And those that are successful have 2 strategies, and that's either they're actively working on losing weight or they're watching their weight. And the fantasy is that you'll lose the weight, figure everything out, and never have to think about it again. That's the fantasy. And we all have our fantasies, We'd love to have a miracle solution to, complex problems. Unfortunately, it doesn't work that way. And one of the things that we do in the weight loss program is we have people go out and talk to people that are, normal weight or ideal weight or desirable weight, and ask them if they keep track of their weight. And they all do. Everybody does. And that always surprises them. They say, well, I thought you didn't, you know, they'll look at somebody who's not overweight and they'll say, well, you don't have to worry about it. But that's not how it works. In this society, it's very difficult to maintain your weight just without thinking about it. Doesn't happen. Let's see. Okay. Maintenance. So these are participants from the weight loss maintenance trial. And this is 3 years after they stopped intensive intervention. And it's broken down by age. About a third of the middle-aged folks were able to maintain a clinically significant weight loss, 5% or more, at 3 years. And about half of those over 60. Well, I mentioned that the older folks do better. Interestingly, when I've shown this slide, people say, well, sure, but older people lose weight anyway. Well, we had a control group in this study, and the control group did not show that. So compared to, this is a real effect. Older folks do better. I'm not quite sure why, but I'm glad to hear it. Okay, now the hard part. How do we get this worked into routine medical care? And this is not an easy question. This is a tough one. And I'm going to show you some data, and then I'm going to make some speculations. And feel free to interrupt with questions if you like. Several high-quality clinical trials have directly assessed this question. Tom Wadden did a very interesting one, and Larry Apple did the other, longtime weight loss researchers. In the Wadden study, they worked with primary care physicians, and there were 3 groups. Patients were randomly assigned to either quarterly visits with their physician with specific training on how to give advice, or the second group was those visits plus monthly visits with a weight loss counselor. And the third one was all of that plus meal replacements and in some cases drug treatment. So here is physician quarterly visits. It's virtually no change. This is weight change in kilos. And you can see that just physicians talking to patients every 3 months had no measurable effect. It was a little better if you added in a counselor. This is with the counselor. And if you put the counselor with some meal replacements, you did better. And the advantage of meal replacements, of course, is you're getting control over what people eat. The Apple study is one in which there were 3 groups, a control group where the primary care physician provided advice, and there was 1 counseling session at randomization. Then there was a personal contact intervention, mostly conducted by telephone. There was a website with information and so on, and also telephone calls from a counselor. And then the third group was group sessions. Let's see here. So here's the control group. No surprise here. Seeing your doc once in a while has almost no effect. These 2 lines, one is the group sessions and the other is the individual, virtually the same. The telephone counseling was popular with the patients because it was flexible, and the scheduling was flexible and could be arranged around their schedule, whereas the group meetings weren't. About the same result. And we're looking at, what are we looking at here? At 24 months, we're looking at 5.5, 6 kilos of weight loss. So primary care physicians are not a good fit for weight loss counseling for these reasons. They don't see patients as frequently as is needed for effective counseling. That's it. There's no way that we're going to be able to have weekly sessions, individual sessions with primary care physicians. Also, primary care physicians aren't trained as weight loss counselors. They have a whole different set of skills. And they're certainly not, it's not cost efficient. Here's the ideal role for primary care physicians in the healthcare system. Diagnosis is critical. Is this a patient for whom weight management is an important health issue? And I think it's very important for physicians to do that, to help patients decide whether this is an issue they need to focus on for their health. Personalized advice linked to the patient's health is very important as a motivating factor. Assessment of interest in losing weight. If the patient is interested in losing weight, move on to something else. And it's not like it has to happen every time. This is a lifelong problem that develops. So if someone's not ready now, maybe they will be in 6 months, a year, 2 years from now. But no point in trying to get them into a weight loss program if they're not interested. It won't work. It'll just make them mad. For those patients that are interested, referral to an appropriate behavioral treatment program. Physicians have tremendous influence on patients with regard to which program they pick. There are good programs and there are crappy programs, and they can help the patient direct to a program that will be appropriate for them. Documentation of diagnosis and advice is important in the medical record, and follow-up at future primary care visits. How did it go? Really important. Now, the healthcare system has a whole different set of responsibilities. I think it's very important to monitor patient weight over time to see what's going on in your population, especially when you're talking about patients that have specific health issues related to their weight. The healthcare system can provide very helpful diagnostic data and support in the medical record and in an electronic medical record and elsewhere. Can help providers pick out the right referral sources. There may be some referral sources that are better for some patients and some for others, and the physician can play a very important role there, and the healthcare system needs to support that. They need to be on top of it. You can't expect the frontline healthcare providers to be doing all this research on which programs are best for their patients. That's something the healthcare system needs to do. Providing feedback for patients is very helpful, showing them what's been going on over a long period of time. And the weights that are recorded in the medical record are probably the most accurate data in the medical record. We've done several validity studies comparing weights in the record to weights in research clinics, and they're highly accurate. And the healthcare system can keep track of what's going on with their population. Most important, they can evaluate programs that their patients are referred to. What proportion of patients benefit from this treatment program? What proportion don't? This is something you can do using the weights in the medical record. This is something we were talking about before this talk started. The importance of patient copayment for obesity treatment. There's some that feel that a copayment is a barrier and it keeps people out of treatment. But in our experience, when people put money into it, they do better, get better results. And we're only interested in results. That's all we're interested in here. So if patients pay a portion of the treatment costs, they do better. And there are a slew of for-profit treatment programs out there that get a lot of money from people. We work with low-income folks. They have all spent lots of money on weight loss programs. So it's not like they're not willing to do it. It's just that you hate to see them put their money into a treatment that's of no effect. And so we've used copayment programs of all kinds at Kaiser Permanente in Portland with good success. And there's a fair amount of research now that show that patients in behavior change programs of all kinds, weight and others, do better if they provide a copayment. Well, here's some things that I think we need to do as we look into the future. I think we need to do more studies on cost effectiveness or return on investment for intensive weight loss programs. I hear all the time, so when I'm advocating we should be doing these behavioral programs, the first thing people say is, well, they're too expensive. They don't know how much they cost if you ask them. Well, I don't know how much it costs, but it must be too expensive. Well, how expensive is diabetes treatment? I mean, if you think about the most expensive chronic condition in adult, middle-aged and older adults is diabetes. It's a huge factor in costs in our healthcare system, and no doubt yours. And how many hospitalizations do you need to prevent to pay for a major program? I mentioned using medical record weights to evaluate and compare the effectiveness of interventions, which I think is really important. I think we need more long-term studies comparing various weight loss maintenance interventions. It's tricky. What we're really interested in is what happens 3, 5, 7, 9 years from now. And that's something you can do when you have a medical care system that keeps weights. And I want to spend more time on this, adaptations to specific cultural groups. I understand there are a number of people interested in that issue here. I've worked with mixed Asian ethnicities in Hawaii. Some of those interventions were delivered in Pidgin, and I went to the sessions, but I couldn't understand most of it. We've worked with Spanish-speaking populations in Oregon and other places, worked with African-American populations throughout the United States. We've worked with Native American populations. And what we found is that it's not just language. You can take the materials that are developed for the white English-speaking US-born population, translate it into whatever language you want, and you don't get very good results. And we've done most of the work that we've done with ethnic minorities have been with African Americans in the United States, and we had really crappy results. The same thing that worked just fine for white populations in New York and Oregon and California and Colorado didn't work very well at all in the South. And we didn't start getting better results until groups of African American researchers got into it and started working on it. And what we realized was that people that look like me, white, English-speaking, US-born researchers working with populations like that, were culturally adjusting our weight loss interventions to that culture. You don't know when you're doing that that's what you're doing, but as a practical matter, that's what happens. So when we've started working with these other populations, we didn't get anywhere until we brought in interventionists and scientists from those populations, and they started doing much better. Now, my colleague, Nanja Lindberg, in Portland, has been doing a lot of work with Mexican immigrants in the United States, mostly women, and she's developed a very different sort of approach. The goals are the same: helping people change their diet, bring down their caloric intake, keeping food records, and so on. But the way in which it's done is very different. And Nanja doesn't have a Spanish name, but she is a native speaker of Spanish, is a Mexican citizen, grew up in Mexico City, and but has done great work with that population. She's published a number of papers. Is that a question back there?
Yeah, I was just wondering, when you say different, what is the difference? Is it the language, or is it because, different cultures have their different cuisines, like different food times? I just kind of wanted to know what that difference was.
Sure. Well, okay. When you working with, now keep in mind, I'm not the one that's working directly with these women, so I'm going on Nanjal's published work and what she's told me about it. But when you're working with Mexican-American immigrant women, these are women that grew up in Mexico as adults and moved to the United States. They have a number of conceptions about food and its importance in health. There's, for example, there's our hot foods and cold foods. This was something I knew nothing about. Chocolate's a hot food even if it's served cold. And there are, you're not supposed to eat citrus at night because it's poisonous, but it's okay in the morning. Wow. You can take if you toast a tortilla, it loses all its calories. If you put lemon juice on meat, it loses all its calories. There's all kinds of conceptions. I didn't know about this. I know the odd dietary thinking from my culture, but I don't understand the others. So the culturally appropriate dietary assessment instrument that was developed, the Southwest Food Frequency Questionnaire, has check boxes, you know, and how often you eat tortillas, and the maximum is 4 a day. Well, she's never had anybody that ate less than 4 a day. They're, you know, 10, 20, 30 tortillas a day sometimes. And these are low-income folks. Tortillas are a major part of the diet, and they're mostly from rural Mexico, and that's the tradition. Well, you know, they're in Mexico. Nobody uses measuring cups. Nobody uses teaspoons and tablespoons. All the stuff we've got is written for that. They don't know what the hell you're talking about. A cup is something you drink tea out of, but could be any size. And most of the Mexican cookbooks do not include quantities. They don't measure that way. They do other things. It's a different culture. They all know how to cook. You work with an Anglo population more and more now. People don't cook. They just don't know how to cook. All these Mexican women know how to cook. So it just, you have to approach it the materials that we develop, the problems you see in some populations just aren't the problems you see in others. And now there are problems that cut across all. Is that helpful?
Yes.
Yeah. But keep in mind that although I'm familiar with Mexican culture, I'm not of that culture, so I'm not the best one to talk about it. But she's getting good results. She's getting good results. Another thing that we found, if in an Anglo population, if they miss a couple sessions, they just never come back. These Mexican women often they miss sessions because of their work schedule changes or they have other problems. They'll come back after 3 or 4 weeks with no guilt, no problem. Yeah. Other cultural differences. In Mexican populations, exercise is a big deal. They all think it's important. You don't have to convince anybody that exercise is a good idea. And in some of the other populations we've worked with, exercise is considered dangerous and not good for your health, and you can work yourself to death. Well, you know, I mean, so the way you approach these things varies tremendously. So it's not just language. It's and if you're not of that culture, it's very hard to see it. It's just really hard to see it. And so when we've worked with Mexican populations, just speaking Spanish doesn't cut it. You know, we had this Argentine interventionist who just couldn't get any traction with these Mexican immigrants. And I got a feeling that a Mexican dietitian probably wouldn't do that well with Argentines. I don't know. This I don't know. But I can tell you that it makes a big difference. So I hope that's helpful. Let's see. We've been using telephone counseling lately. I like group sessions because they work so well. They really, really work. And they work in all populations we've worked with. There's something really powerful about that group connection. A skillful leader can use that group support to fire people up, to get them going. They get to the point where they come back. Even if they haven't done well, they come back because they don't want to let the group down, yada, yada. It works really well. The problem is that it's not flexible enough. The locations where you hold group meetings can't be changed easily. The times can't be changed. And so there's problems there. Lately we've been experimenting, and others have, with telephone-based counseling. It works pretty well. It's not quite as powerful as group sessions, but it has so many advantages. Much more flexibility in scheduling. People that have transportation issues aren't a problem. You could do a national intervention study out of one location with telephones, for example. So people in rural areas or have transportation issues can participate. We've been working with, we'd love to use some new communication methods. We've experimented with text messaging and email and lots of other approaches. They all work some. hopefully this, virtual reality is, technology is going to come along and we'll be able to do really interesting group sessions. Telephone conference calls don't work very well. Not that anybody here would do this, but some people nod off on telephone conference calls. We've used attendance deposits with great success in smoking cessation programs, and we think it would work great in weight loss. I haven't been able to convince the study section to fund one, but I think you put up, when we did smoking cessation, we had people put up $100. If they didn't show to one session, they lost 50. They didn't come to a second session, they lost the whole 100. And we would get 90% attendance. When we took the attendance deposit away, it went down to 60% attendance. And there were no exceptions, none. If you had a temperature of 105 and were in danger of dying from pneumonia, you still lost $50. And when we did that, we had much better long-term results. When we did biochemically confirmed stuff for 1 year, we did better. I think we do better in weight loss too. I just can't convince the funders to go for it. They think it's a barrier, it's not fair, taking money away from people. But it's much more powerful if they put up the money and get it back only if they participate than if you pay them. And there have been studies where people get paid to do it. It doesn't work as well. There's something about your money coming back that's powerful. We've been doing work on early life interventions. I mentioned the Healthy Mom study was, this is one that was scary. The obstetrician colleague came to me and she said, I'm having a lot of trouble with these high-risk pregnancies. My patients are having all these health problems and delivery problems, and if they just would lose some weight, they would do better. And she said, what can we do to help pregnant women lose weight? And I said, we can't do that. That's dangerous. But it isn't, it turns out. So we went into the literature and we found a bunch of observational studies that have been done showing that women that, now I'm talking about obese women now, that don't gain much weight or even lose weight during pregnancy tend to have easier deliveries, tend to have healthier babies, tend to have fewer complications. Better outcomes all the way around. So we did a study where we actually, we located women as soon as we found out they were pregnant in Kaiser Permanente, randomly assigned them to one of two groups, an intervention group or a control group. The intervention group met weekly until they had their babies and did better. There were no downsides, and they tended to do better. They did gain weight, but not a lot during their pregnancies compared to the control group. We've published it. The first author is Kim Vesco. We've now doing a study but the problem with that study is we pick up women at 14 weeks into their pregnancy. So now we're working with women that are anticipating pregnancy and working with them through their pregnancy. It looks like we'll have about 150 women total that became pregnant during the study. And we're still collecting, haven't quite finished intervention yet. But we think that intervention in that first trimester will have the greatest effect on reducing the risk of the children becoming obese as adults. Let's see. Now, I can go on, but I assume people will have questions, so this would be a good time to ask questions. Yes? Yeah?
I have a lot of questions, but I'll start with the control group. We talked about that. Have you looked at attention control versus usual care at all? You talked about the benefits of the class or the people just not doing anything.
So the question is, what constitutes a control group in these various studies? And it depends on the study, but usually it's whatever normal healthcare would be. So with the pregnancy study, we recruited Kaiser Permanente patients who were already getting high quality obstetrics care. And so they got their regular obstetrics care, which is above the national standard, or they got that plus our weight loss program. In some of the other weight loss programs, usual care consisted of no treatment. Or maybe we give them a brochure saying, here's how to eat a healthy diet. Did that answer your question? All right, there was another question, yes?
And can I interrupt for just 1 second? If you'd like, we'd encourage everyone to come up to the mic so that everyone can hear the question and then also the response, as well as for our videographer too.
Okay, so there's someone at the mic.
First of all, thank you for invigorating presentation. I appreciated that, especially when you talked about integration of all these techniques into day-to-day practice. Now, I think that's excellent. However, my observation is one of the flaws in any kind of research is that there's not sufficient amount of integration between the various research groups. So therefore, the conclusions that we draw from these studies are not as effective as they otherwise would be. So I'd like you to comment.
Well, unfortunately, I agree with you. I think that's a problem. The weight loss studies that we've done at Kaiser and Portland have resulted, some of them have been moved directly into patient care services, and that has gone well, but not all. And there's a reluctance sometimes to fund. One of the problems that we're having, let me see, I think I even have a slide on this. Barriers. Here are some of the barriers to integrating weight loss treatment into care. There's a prejudice that behavioral treatment programs don't work. And I hear this all the time from frontline clinicians. They'll say, well, nothing works and all my patients just want to, or it works, but everybody regains weight, or it's too expensive. And, or more likely, I'm not comfortable. These are common barriers. I don't know, often the issue is getting the healthcare system to pony up the money. They don't want to put out the money for treatment. I don't know what to do about that. Here's the thing. I've been at this for a long time. I didn't have one gray hair when I started this work. I was just a kid. And we could see this looming obesity epidemic, and we would go to the health plan managers and the medical group, and we'd say, you're going to have a diabetes epidemic. It's coming. And they'd say, well, yeah, but I got to balance the sheet this month, this week, this year, next year, and this diabetes thing's not going to be here for a long time. And so you could see it coming, and we would talk about it. We'd go to the Obesity Society meetings, and people would talk about this coming thing. But we couldn't get the attention of the healthcare funders. And if you could help us with that, that would be good.
So I agree with the funding aspect of it, but I'm thinking loud. If our research individuals were to be, for a temporary time frame, transplanted into where the real field work is, which is in the primary care, doctors' offices, and so on and so forth, I think that could be beneficial.
Well, I agree with you. I think that would be a good thing to do. Yeah.
I want you to disagree with me, but you don't want to. So thank you.
Well, you had a good idea. What can I tell you? I think researchers don't want to develop stuff that's never implemented. But a lot of the work that we've done has been around questions of does weight management improve blood pressure control? Does weight management improve glycemic control? And those studies are done without concern for whether this will be implemented or not, but just in the basic science perspective. But others are done with the direct. I don't want to embarrass my host healthcare system, but I developed a smoking cessation program for hospital patients and proved that it worked in their system, and they didn't implement it. But a number of hospitals around the country did implement it. So I felt good about that. I mean, it's sometimes, there's a saying in Portuguese, even saints don't do miracles at home. And, yeah, next question. Yeah.
So Victor, so we're about to embark on kind of an unprecedented experiment where Medicare is going to pay for the National Diabetes Prevention Program, which is has all the components you describe, which is a behavior change program. It is about weight loss. People weigh when they come in. So any comments on, we're going to get a try, that drug's going out to the community. Any comments on, predictions of success or how hard this is going to be? But so for everybody to know, Medicare is going to actually cover a year-long program to prevent diabetes in patients that have risk of diabetes for the first time. And so any comments on the National Diabetes Prevention Program movement?
Well, I think it's going in the right direction. I'd like to see a systematic evaluation of it. We've been working in our healthcare system, I expect you have too, trying to get them to implement it in such a way that you can evaluate it, maybe a stepped implementation process where you provide it to some of the patients and then see how you do, and then some more, and then some more. So you've got something to compare. My concern is that what they're doing may not be intensive enough, but you can use the data in the medical record to evaluate it. So even patients that say, to hell with your program and don't come back, you'll still be able to find out what effect it had. And I think that'll be fascinating to find out. I just think we need to have a systematic evaluation of these things. So there's a lot of talk about making the healthcare system a learning system. And it's all about systematic evaluation. And for that, you have to be able to compare things. You can't just go on the fly. And so I hope that, knowing you, I suspect you're planning an evaluation. Yeah.
Yeah, I'll just say, Intermountain and Health Insight, we're, working with the CDC on that, and we'll see how that goes.
Well, I don't think anybody has a better reputation for evaluating actual care implementation than you guys. I mean, you're the leaders.
Can I just ask a key off of that question? When you say intensive, because it's my understanding that's a once a week meet for like a year. That feels pretty intensive for a patient to commit to that.
Well, there's different models that are being implemented.
Yeah, it'll be once a week for, I think, 3 to 4 months, and then once a month for the rest of the year. And then they're also looking to pay for that second year of support. So, it follows a lot of the models you described.
Yeah, I'd like to see it more intense. I'd love to see weekly for at least 6 months, and then maybe every other week for the rest of the year. But however they do it, I just think they should set it up so that they can evaluate it. So it's evaluated with your patients in your system, in your region, so you can see what the hell's really going on and how much benefit are you getting. And we should be doing that with all of our health care, and Intermountain's a real leader in that area. But with that particular program, did that answer your question? Yeah, Mike?
Yeah, so I'm interested, you talked a little bit about the role that healthcare systems can play. And I'm interested your thoughts on not necessarily the weight loss phase, but the weight maintenance. We have in primary care, we have care management teams, we have care managers that are reaching out to patients, medical assistants, et cetera, over a long period of time, not just that initial weight loss phase. Health insurance companies have their care management teams as well that are reaching out to patients. I'm wondering what you think the role is that healthcare systems can have with the more attention that's being paid to reach out to contacting patients on a more frequent basis, and maybe that, I guess, the maintenance phase of weight loss.
Sure. Well, and that's quite a challenge. So the question about, how can healthcare systems improve long-term maintenance? I would like to see in every healthcare system a behavioral health unit that focuses on that very question, on long-term follow-up. We know from a number of randomized trials that continuing contact helps, and more frequent contact is better than less frequent contact. It'd be very interesting to have a department that focused on that and experimented with different ways to communicate with people. We think that text messaging is probably really helpful. We've experimented with websites where people would enter their data and so on, and depending on what they enter, the counselors may target them for more intensive treatment. There's some indication that people that fall away can benefit from coming back and going through initial weight loss again. But you need human counselors keeping an eye on that stuff and trying to figure out what's going to work with the patients. And it doesn't all have to be telephone calls, but we know that works well. But I think that automated systems can also be made to be more effective. We need some clever people to put some energy into that. I hope that answered your question. I just don't think that the primary care doc, with the way they practice medicine in the United States, can do much of that. I think it really needs to be a specialized department. And I would include other things besides weight management. I'd put in addictions treatment and other behavioral tasks with that department because there's a lot of other things that we need to be keeping up on. And the skills that you want in a counselor are pretty much the same for addictions treatment, weight management, exercise, falls prevention. There's another question? Oh, well, okay.
Hi. So I'm just wondering, how might the effectiveness of these different interventions change with a group of people who maybe are just starting their weight loss journey versus a group of people who have lost weight, gained weight, lost weight, gained? Have you looked at any of that? Is there anything in the literature about that?
Well, when we work with middle-aged and older people, almost all of them have been in multiple programs or have made it multiple efforts. It's very rare that we get somebody starting for the first time. With the younger folks, we do. But with middle-aged and older folks, they've all been at it before. And we've done well with them. Think of weight management, that the behavioral skills you need for successful weight management are cumulative. And each time you go at it, you learn a little bit more. And you do get better at it with time. And one of the goals of the intervention is to help people see it that way. Because the tendency to say, well, it didn't work last time, I'm a failure, as opposed to saying, well, it's like learning to ride a bicycle. You know, you fall off, you get back on, you fall off, you get back on, eventually you got it. I mean, it should be cumulative. You learn a little more each time. And, but the support that the program offers is always helpful. Another question.
How long on average are the group sessions? And also, I'm assuming in the group sessions there is a part of it that's educational. And what percentage, you know, is it 10 minutes out of an hour that's educational, or is it half of the time? What type of percentage are we looking at?
So for initial weight loss, typically about 90 minutes, sometimes more. For the longer term programs, so maybe an hour. We always have information in there because the participants love it. It's very popular. I don't think it has much effect on weight change, but it helps keep people's interest up, and that's important. It's real important. So we always have maybe in an hour session, 20 minutes of informational stuff. But if you're reading their food records and you come in and you do an informational session on some kind of food and it never appears on their food records, then you kind of know it doesn't change behavior. But people like it. It helps keeping them come back. It's not a bad thing. Did that answer your question? Yeah, it's frustrating for those of us that have been trained to provide information as a behavior change tool. It doesn't work very well.
I was just wondering if you've done anything where you provided obviously the professional support and information, anything, but partnered with community groups that are providing the kind of peer support and exercise and things like that, because the community I work in actually has that aspect.
We have, and with very checkered results. Some people have a real knack for working with other people and being supportive, and other people don't. And the peer support programs that work the best are pick people based on personality. And there have been some real successes with older folks. There was a study done in senior centers in Minnesota or someplace that had really good results. But they were very careful on who they picked. You know, they picked people that had the right kind of personality, sort of outgoing, charismatic types that would be positive. Not just anybody can do counseling. You'd wish they could, but they can't.
So when you're getting these patients for these studies, how do you incentivize them to be a part of the study? So you were saying that 150 women who are part of the weight loss program. So do you incentivize them with the monetary incentives, or that kind of becomes a habit for patients that you need to pay the money to be a part of a health change which is good for them, or do you incentivize them, or is it on the physicians or somebody to convince them that they should be a part of this program? How do you get them into it?
Well, that's a good question. How do you get people into the programs? We've done it every way you could imagine. We've done television ads, we've done radio spots, we've done interviews with newspapers. When we're working within the healthcare system, we usually give them a mailing. We know their address because they're health plan members, so we send them a letter and we say, we have this program. If you're interested, or you know another health plan member that's interested, have them call this number, or go to this website, or whatever. And with the pregnancy study, we sent a letter to every woman that tested positive on a pregnancy test. So we've done it different ways. The recruiting from within the healthcare system seems to work really well, and we've got a good reputation. Well, we're out of time, and I'll be around at the break if you want to ask other questions. And there you go.